Good morning, everyone. Welcome to our fifth Project Echo session for addressing barriers to healthcare and cancer prevention screenings for adults with intellectual and developmental disabilities. We're so excited to be with you today in our Zoom room. My name is Michelle Jansen, and I'm the Community Outreach Coordinator on our team here at Rutgers Cancer Institute of New Jersey. As the state's only NCI designated comprehensive cancer center, our goal is to prevent cancer before it starts. In New Jersey, cancer is the second leading cause of death. 1 in 2 men and 1 in 3 women within our state today will develop cancer at some point in their lifetime. We know that those with an intellectual or developmental disability experience a greater number of health disparities that can lead to a reduced rate of preventative screenings and a higher number of cancer diagnoses. Before we introduce our moderators and presenters for this session, we would just like to share a few tidbits of information about our Project Echo series. We encourage everyone to turn their cameras on if possible, just to encourage the flow of dialogue and the exchange of information and resources throughout our session. And we also just like to give everyone a gentle reminder to just be sure to mute your mics while our speaker is presenting, just to reduce and minimize any background noise. But we do encourage you, of course, to unmute yourself to provide feedback, suggestions, ask questions throughout our time today. And if you are also more than welcome to enter any questions that you have in the chat box as well, and our team will be monitoring that. So the first part of our Project Echo session is going to involve an evidence-based presentation that will lead us into an open conversation about best practices and developing solutions for common challenges that we may face in our practice and the provision of services to individuals with special needs. Everyone in our Zoom room today is an expert in their own right and through their own very unique skill set and experiences. Our goal is to bring all of these combined skill sets and experiences into one place where we can discover new approaches, build a set of evidence-based practices, as well as to share resources and connections to enhance the care that we provide in our different disciplines. I'd like to introduce our panel of moderators for each of our Project Echo sessions. This is what we refer to as our Project Echo Hub, and we're going to be with you for the next 3 sessions of this series, and we will help to guide the conversations, moderate the chat box, and just really be here to get that spark of conversation flowing. We're also going to be sharing a box folder with you so that we'll have all of the materials, the PowerPoint presentations, evaluations links, everything that you'll need for each session. So I would first love to introduce my wonderful colleague, Sherry Lynn Cognetti, who is the current president of the North Jersey Health Collaborative. She's going to introduce our session speaker and topic area for today that will be presented by Laura O'Reilly Stanzilis. Welcome, Sherry.
Good. Thank you, Michelle. I just want to say briefly that as president of the collaborative, I value the strength of partnerships in working to address the health of our communities. I thank you for taking the time amidst your busy schedules to join us in this important work and hopefully make connections that we can further the work. I'm very proud to present to you Laura O'Reilly Sandless, who is the executive director of the North Jersey Health Collaborative, an organization with a diverse set of partners and a hub leader of this Project Echo. Its core function is a shared process of community health needs assessment and health improvement planning to identify the most pressing needs and facilitate the development of collaborative strategies to address them. Laura has worked extensively as a certified personal trainer, group fitness and yoga instructor, and fitness program manager in New York City and New Jersey. She was a member of the Developmental Disability Nurses Association and served as the Director of Health and Wellness of Easter Seals, New Jersey, where she and her team created the first accredited special needs structured exercise program in the U.S. through the Institute for Credentialing Excellence. In addition to being an RN, Laura holds a bachelor's degree in arts and communications and a master's in management of public health and public safety. She is currently a member of the Morris County Human Service Advisory Council and is past president of the New Jersey local boards of health association. She served on the New Jersey Department of Public Health Standards Committee and the New Jersey Division of Aging Chronic Disease Self-Management Committee. She has been a keynote speaker for the New Jersey Commission on Recreation for Individuals with Disabilities and is a passionate advocate for supporting the health and wellness of individuals with disabilities and special needs. We welcome Laura. Laura, unmute.
I'm muted. Thank you. Thank you, Sherry, for the introduction. And thank you, everyone, for taking time this morning to be here today. I just wanted to look at you all before I pulled up my slides because I cannot see you. I'm going to be sharing lots of information, but at the end of the day, this is about addressing the barriers to accomplishing these goals set herein, and also ways in which we could work together to support the health and well-being. There's a lot here, and some of the stuff that I will touch on will be presented by other speakers coming up or have been presented already. So without further ado, I will just get started. And please, if you have any questions, put them in the chat and Sherry will call out your questions afterwards. Now, allow me to share my screen without, oh, I did it. Okay, so I would like to know if, slideshow, you see my screen, right, everybody?
And we can see Laura, yep.
Okay, so slideshow from beginning. Here we go. All right. Health, wellness, and cancer prevention in residential and community-based programs. Now, community-based programs could be programs that are implemented by disability service agencies, community organizations, recreation programs, public health, mayor's wellness, etc. So there's a lot of ways that we can engage individuals with disabilities, IDD, and other disabilities in wellness programming that will improve their health outcomes for life. So, according to the National Cancer Institute, despite limitations of study designs, there is consistent evidence that higher amounts of body fat are associated with increased risks of a number of cancers. There is definitely a correlation between obesity and cancer. Now, despite the limitations of study designs is something I'd like to point out, because when looking for data on cancer and disabilities, screenings and disabilities, obesity and disabilities, or underweight and disabilities, there's a lot of conflicting data. But everybody will agree that those with more sedentary lifestyle and less access to healthy foods and who are on multiple medications are certainly at an increased risk for disease, for cancer. 42% of American individuals with disabilities are obese. Now, this number goes back to 2011. And for today, I just wanted to make sure that I could get some current data. The last data I was able to find from 2014 still had the same number. Newer data, again, is showing that some, depending on the type of disability, there's underweight. So you understand that, you know, being underweight also has its risks and challenges as well. So it's about adequate nutrition, enough to keep our body healthy and our muscles and bones strong and all systems working as they should. We had discussed this at a previous presentation here, that individuals with developmental disabilities are more likely to be on obesogenic medications. Those are medications that slow down metabolism, increase water retention, or for other reasons, cause weight gain. One of the things that we could all agree on for anybody is that the more we embark on a healthy lifestyle, the less need we have for certain medications. And we understand that people with developmental disabilities are on different kinds of medications, some for chronic disease, others for seizure management, etc. So there are certain medications that cannot be reduced or eliminated, but the ones that we can reduce or eliminate will lessen the amount of medications that an individual is taking into their body. Other studies suggest, this goes back to what I was saying earlier, that those with IDD are at a risk for unhealthy weight. So we use healthy weight as our goal, right? It's not being skinny, it's not being thin, it's not being overweight or underweight, it's being healthy. Whatever your normal body mass index should be according to your height and your level of activity. Researchers have consistently reported that severe or profound intellectual disability is associated with being underweight, and that relatively mild intellectual disability is associated with being overweight and obese, and also caused a higher risk of obesity compared to being overweight. But I do want to point out, I highlighted this. Dr. Kelly Shea in 2014 found that that there wasn't any significant difference in the prevalence of morbid obesity across intellectual disability levels, which I find very interesting. And I would just share at this point that when I was running a program at Easter Seals, I had worked with Dr. Shea in a 5-year longitudinal study on disabilities and health and wellness. And what was really interesting was that I was starting up a program with a very generous grant, and I was not told who was in the study and who was not, but we started concentrically at one employment services center in New Brunswick. And then over the 5 years, we had expanded the program out across 21 counties in New Jersey. So that by the time this study was done, we had a lot of people involved, and it was Dr. Pronounced Shea, Dr. Kelly Shea, who was overseeing this project with another researcher at the University of Illinois. But I would like to say that we had some remarkable outcomes, and that over 5 years, there was definitely an improvement, self-reported improvement, and some weight management that was demonstrated, and also self-reported and family-reported changes in lifestyle habits. So my point here is that when an intervention is put in place and the attention is consistent and the habits are changed over time, the outcomes improve as well. People with disabilities have greater incidences of chronic illnesses like diabetes, hypertension, high cholesterol, and other related health complications. In fact, hypertension and high cholesterol were among the top 3 indicators for individuals with developmental disabilities. In this longitudinal study, obesity was number 1, which is why I suppose Dr. Shea has that standalone data related to underweight, overweight, healthy weight. This is a public health document, the Surgeon General's Call to Action. So this is the Surgeon General's Call to Action to improve the health and wellness of persons with disabilities by Dr. Richard Carmona, who I saw on a TV commercial this morning, by the way. He's one of the public health figures that are coming out talking about COVID. But interestingly, back in 2005, when he was the Surgeon General of the United States, he put out this call to action, and I'm going to read it verbatim because it's important to underscore, and I'm sure I'm preaching to the choir, but disability is not an illness, right? So if we look at anybody's baseline health condition, we look at ways in which we can improve the person's health and physical status working from that baseline, right? So the disability might be a baseline, and there might be limitations related to a disability, but anybody can improve their health status with the proper interventions. So with the recognition that disability is not an illness, the emphasis increasingly is on continuity of care and the relationship between a person with a disability and the environment at the physical, emotional, and environmental levels. This approach is based on the knowledge that good health means the same thing for everyone, and that the best possible health status and quality of years of life should be a goal for everyone, whether experiencing a disability or not. We all know how better we feel when we eat better, when we get enough sleep, when we get some exercise, when we take our medications as prescribed. It's no different for people with disabilities. So how do we respond to that? That is a public health document, right? The Surgeon General's Call to Action is a public health document. So how do we promote public health and prevent disease among this population? Well, let's start with the general Healthy People 2010 and 2020 documents that identify overweight and obesity as a public health issue. There are national objectives in place for the reduction in their prevalence. And I'm going to digress just a little bit to share with you that back in 2010 and 2020, well, let's go back to 2010. Back in 2010, it was stated that 1 in 3 children born after the year 2000 are anticipated to be overweight as an adult and will be at risk for adult onset diabetes. So in Healthy People 2010, they're saying that 10-year-olds of that time in their adulthood, 1 in 3 will be obese. So then looking ahead to Healthy People 2020, which has passed, that projection was still the same. Now we're working on Healthy People 2030, but I would like to share briefly a study that we did with the North Jersey Health Collaborative with some schools in Sussex County. And it's not we, I give credit to the Sussex County Health Department and our Vice President, Maureen Cianci, for that work. But they took the BMIs of 5,800 kids, and 1 in 3 kids is overweight or obese. So this is an ongoing thing, and we have to continuously work on the childhood and adult obesity and overweight situation in this country. So if you look at the general population and the prevalence of obesity, noting that individuals with disabilities have a 13% higher chance of being obese, we really need to pay attention to these citizens in our community and help them stay healthy. So improving the health and well-being of a community must ensure that every individual has access to and benefits from policy, systems, and environmental changes enacted on behalf of community improvement. We at the North Jersey Health Collaborative we're in the business of community improvement, right? We are working on the Community Health Improvement Plan now, and our goal is to encourage inclusivity in all community health and wellness promotion programs. And that is by connecting public health with disability services agencies, releasing information about sensitivity training and how to do screenings and provide the education on an ability appropriate level. Responding to this call to action, here's something I'd like to share, and it's something that I've been thinking about for a long time. So let's just talk about emergency preparedness, right? There's the Register Ready database where an individual with a disability can get registered with the state. And in the case of a natural disaster or some kind of emergency, you know, the people with a disability are listed in that database. And we also understand that in a managed residential environment, there is staff and there are organizations that are looking out for the well-being of these individuals that live in the community. But what's interesting is, you know, when you look at a community, you look at a municipality, you look at a neighborhood, a lot of people learn about what's going on in town and learn about the health fairs and the screenings and other events of the local Office of Public Health, essentially by being involved with the school, or being involved with the seniors club, or being a volunteer, or signing up for the reverse 911 so that the town could communicate out information. People who live in a residential program that is run by a disability service organization live in a house that is essentially managed by 24-hour staff. Right? And those staff don't live in the community in which the consumers reside. So you have staff coming and going in 8-hour shifts, doing wonderful work and supporting the lives of the consumers that they're serving, but that's not necessarily connecting the consumer with their town. So one of the things that can be helpful in this is putting out a memo of sorts or information to disability services agencies and ask their management teams to identify the location of their local Office of Public Health. And if it's a shared service, you know, find out where they are through the municipality, call the local municipality, get on the email distribution list for events in the community, learn about what's going on in the recreation committee. And by reaching out to the municipality and the local office of public health, they can be supported. I remember during Hurricane Sandy, one of our public health nurses went to Menin Arena, which is in Morris County, which was a staging area after Sandy, a place where people were being transported because they didn't have power. But our public health nurse went around this warming center and just checked with all the seniors to make sure that they had their medications. Now, again, we've got residential programs run by organizations that will look out for the needs of their consumers in a case like this. But then you have people with disabilities living in the community with their families and are not supported by an agency. So that's just, you know, one of the many ways, or two of the many ways in which public health can really get involved in supporting the individuals in the community who have developmental intellectual disabilities. Regular preventive health screenings can help people with IDD remain healthy and have a good quality life. And health and wellness education may improve mobility and lifestyle habits and lower the risk of obesity-related illness. Now, you'll notice what I'm saying is pretty much what is the rule for the general public. And we underscore, again, we're preaching to the choir here, we're underscoring that individuals with disability have these needs too, and these needs must be served. But each individual is unique and has a different set of needs and means for achieving those needs. So if it is a person who lives at home with a family member with a disability, their access and transportation might be different from an individual who lives in a group home, who has staff who perhaps can't leave the facility because they are working with other consumers, and perhaps the staff accompanying them to a screening or a doctor's appointment don't really know their personal and family health history and may not be able to provide a history to healthcare professionals. Another situation would be that an individual has some anxiety related to a screening, and a staff member may not be trained in supporting the person through this process. I'll go on a little bit about that when I get a little more into screenings. But there are, again, barriers that we continue to address so that we can achieve the best outcomes and have these screenings and healthcare visits be successful. Policy systems and environmental changes are not applied equally to every member of a community. Again, this is an access issue, and transportation is a huge issue across the board for people in terms of accessing healthcare and services, and particularly so for individuals with a disability who may need to go out into the community for healthcare, and also to take an exercise class or a nutrition class or do something enriching that will improve their well-being. So not having transportation and not having access to these services clearly increase health disparities. I went to a population health symposium in Washington, D.C. a few years ago for people with disabilities. And what was really interesting is the speaker said, if you look at marginalized communities, marginalized people, and how they have limited access, and the social determinants of health really indicate that they need more support and we don't know how to get to them or get them services. They said, look within those populations and you'll find that the people with disabilities are in the farthest corner of that, you know, because a lot of families have a hard time advocating for the needs of the individual with a disability. An individual with a disability may not be able to articulate their wants and needs or how they're feeling. They may be nonverbal. There are many reasons why we need to be proactive and anticipate rather than expect the consumer to come forward and share state of need. This is something interesting that I'm really proud to have been part of. This is something on the national level. When we talk about what can be done nationally, what can be done locally, this is national and local. But the National Center on Health, Physical Activity, and Disability, funded by CDC, is in partnership with community agencies to correct the gap to create an inclusive community change process. Inclusive health coalitions bring organizations and communities together to improve and promote outcomes, healthy outcomes for individuals with disabilities. So again, we're talking about working together, breaking down barriers, and building a network of support. And if there's, a lot of repetitiveness in what I'm saying, it's because working together, breaking down barriers, and building a network of support is what the North Jersey Health Collaborative does. That's what we do. And by having communities working together to do the same for individuals with disabilities, breaking down those silos, working across sectors, we too can improve the outcomes of individuals with disabilities. Now, this part's going to get a little tricky here because I'm going to play a video. And if I run into a little technical issue, I may need to stop sharing my screen and then restart. Commit to Inclusion is the motto of a coalition that is driving health equity initiatives for individuals with disabilities. This video link here is the Essex County Inclusive Health Coalition. It's a community exercise partnership. I was the leader of this coalition, and it's memorialized on the NichePad website. But I would love for you to enjoy this. It's less than 2 minutes, and you will see how coming together with a municipality and creating a recreation program in a community setting has impacted the lives of individuals with disabilities in Essex County, New Jersey. So let's see. Everybody see the screen? Can somebody just shout out?
We can
Yes.
see Laura.
Okay, great. Thank you.
As the lead organization for the Essex County Inclusive Health Coalition, Easter Seals New Jersey has engaged in several partnerships and programs across the community. One of their first successful endeavors came from partnering with the Maplewood Township to provide its Easter Seals New Jersey Health and Wellness program, Be Well and Thrive, in a broad community setting.
Easter Seals New Jersey's mission is to enable individuals with disabilities and special needs and their families to live, learn, work, and play in their communities with equality, dignity, and independence. These new partnerships are really allowing us an opportunity to extend our mission beyond our programs. Our first partner last spring in the Inclusive Health Coalition was the Township of Maplewood, New Jersey.
The Easter Seals North Chapter found out about us because we have been touted by the Mayor's Wellness Initiative in Trenton. We started talking with our health officer and with our recreation director about what we could be doing in terms of doing more to be inclusive. Through Easter Seals, we became part of a project that brought exercise to the community and directly dealt with the special needs that people have in terms of moving their bodies, being safe, being flexible, etc.
We brought our Easter Seals New Jersey program, which is a structured, ability-appropriate, functional exercise program designed to enhance one's ability to perform activities of daily living.
I helped write this exercise program with the Easter Seals Be Well and Healthy team. We can teach these classes to a variety of individuals. You never know who's going to show up on a particular day or how their mood might be or what their body may be doing that day. So we work with what we have at each class. As people got stronger, we might give them extra reps. We also ask them to make eye contact, to smile, to repeat the person's name to make sure that person is ready to catch the ball and then throw it. That's a lot for them to do. That's multitasking at the most. So we make it for all levels.
There have been both physical and social benefits to the program.
We've had almost miraculous results.
We did notice that they benefited from the program and they enjoyed the program. So I think you both had exercise and you also had a community involvement where everyone was able to talk to each other. And that's something I think that needs to be done for those that need that kind of practice, need that type of interaction.
I'd like to expand this It is a unique program. It deals with so many needs at once, physical and social.
We've actually had classes mixed with an older population that came in because they wanted to work out very slowly and clearly. Everybody got along perfectly. Everybody cheered everyone else on. It was a very cooperative class. And we had some younger people in that classroom also, which was also a lot of fun.
They improved their coordination and they enjoyed it. A major part of exercise. If you can have people enjoy what they're doing, they're more likely to continue it.
Okay, let's see if I can get my slides back up. And can you see my slides again?
And this is perfect, Laura. Yep.
Okay, good, without a glitch. So I felt it was really important to share that because, you know, that was 8 years of my involvement in the community and bringing people together and watching the amazing results. We had a mayor's wellness campaign, which is something that the collaborative will be addressing later on this year, embracing special needs programming, and we had tremendous outcomes. And I will talk about other programs because there are other programs in the community similar to this, and getting involved with communities and getting involved with multiple sectors helps to expand the outreach. Here's one example of how these programs are very successful. This is Mr. E. This is related to a health and wellness lunchtime workplace wellness program in an employment services program. That used to be called sheltered employment. Now it's called the employment services program and vocational training programs, where individuals with disabilities go into a workplace and they have assigned stations and assigned jobs, and some work there for many years and others learn job skills to go out into the community and work independently. But I remember the first day of a nutrition education class, an ability appropriate nutrition education class that we based on, if you're interested, the book is called Health Matters by Beth Marks, PhD. She's with the Disabilities Center of the University of Illinois in Chicago, and she created this amazing book that's available on Amazon. And it is a wonderful evidence-based, which is the operative term here, program to help to improve health and wellness for individuals with disabilities, where you don't have access to a structured program like Be Well and Thrive, or you don't have access to a fitness facility that specializes in special needs. But Mr. E will come into class and he had 2 to 3 Pepsis every time. And he would, very big guy, and he would pound the Pepsis down on the table. And time after time, I kept trying to explain to him, I had these little test tubes with sugar and showed them how much sugar was in the soda, convincing them, you know, what the benefits of water were. But then I figured, let me hit Mr. E in his pocket. And I explained to him that a case of water with 24 bottles costs $4, and 6 sodas, 6 Pepsis cost $3 or $4. So if you're going to work every day and you're earning all this money, wouldn't you like to save some? And his big complaint, talk about a barrier, his complaint was that he would ask the direct support personnel in his group home to buy him water. And they weren't really listening, and they, you know, they just kept replenishing the soda. But it was, you know, we really instilled this kind of self-advocacy in them. And once Mr. E realized that he could, you know, save some money, he really was very persistent in asking for water instead of Pepsi. And then he started coming to class with 1 water and 1 Pepsi. And then he only came with water. And when we did the routine weigh-in every 12 weeks, we would weigh them. He lost 5 pounds by making this one change. And he was so proud. And we had pictures of him in various promotional materials showing him, you know, holding up his hands, demonstrating his 5-pound weight loss. And just like anybody else, when you lose that first 5 pounds or you hit those little milestones, you're proud of yourself and you're empowered and you feel motivated to keep going. And so we had a lot of stories like that. Mr. W would take that structured class that you just saw. He could barely get up. 2 or 3 of us had to help him up out of the chair at a time. And, by the end of several months of the program, we had a sit to stand exercise. It's a chair squat essentially, but done very safely as a functional exercise, strictly to help the individuals be able to get themselves in and out of a chair, toileting, self-toileting, etc. So, this was definitely functional exercise for activities of daily living. And he was able to stand on his own through the participation of this program. This was remarkable. And then we have Miss F, who felt empowered. They made her feel confident. She felt that she could accomplish anything. She became the face of our program and would actually come and speak on the program at conferences. And this is an adult woman with a developmental disability who felt that when she could put together her own meals and understand how to group foods for the best nutrition, it was empowering to her to realize that she had a handle in her own health. So how can we improve the health and wellness of adults in Disability Services Agency program? Well, by integrating these programs in community support and day programs, employment services, do a little lunch and learn, supportive residential programs, but most importantly, because of funding issues. Our program was grant funded at Easter Seals. And when we went into the Medicaid fee-for-service model, it became a little more complicated to integrate these programs into the service plans of individuals based on the billing. And if any of you work in this in industry or understand Medicaid fee-for-service, everything is billable in 15-minute increments. So that was certainly a barrier. So we had to overcome that. So what we did was created an organizational culture of health and wellness. And before I left the agency, I created an onboarding training program for all new hires for direct support staff, so that when they're coming into the organization, they have to go through this training as part of their, again, onboarding process. And what we asked them to do was adapt some of these healthy lifestyle behaviors and model them, because there were times where I would be there with the consumers and my staff doing these programs, and the staff would walk in with a bag of Doritos and a Pepsi, and I'd be like, oh, come on, help me out here. So it was important to kind of create this health and wellness program. And the same could be said sometimes in mental health services industry. You have staff who would smoke cigarettes with the consumers as a way of bonding with them, but it wasn't modeling healthy behaviors, so there was a lot of training around that as well, that there are other ways to bond, and you could bond on doing healthy activities. So I mean, there are solutions. We just have to be creative in these solutions, and when possible, engage wellness professionals, right? Individuals with disabilities, they do have special physical needs at times, and we want to keep them safe, and we want exercise to be something that will enhance their function and reduce and minimize the risk for injury as much as possible. Inclusion in the community. So Special Olympics, we've got Amelia Hamilton on today, so I thought I would just share with all of you. They have wonderful programs in many counties, and if you go on their website, you can find local programs. And they also have healthy lifestyle initiatives. And, perhaps Amelia can, talk a little bit about that before we finish. And I'm going to move more quickly to give her a chance. And then we have community-based programs. We've got Lynn Aloff on the call, and she's with Certified Fitness Special Needs. And it's an example of a special needs exercise program within a fitness center environment in the community. So these do exist. And if we can get more of these to exist, then there's more access for people across the entire state. But these are the different ways in which we can enhance. A lot of YMCAs, Sherry, our president, who you met earlier, her Fanwood Scotch Plain YMCA had an inclusive exercise program as well. So YMCAs are also adapting it. You'll see a lot of special needs aquatics programs, school physical education programs, community health fairs and outreach. But again, I cannot overemphasize how important functional exercise is. And then of course, involving caregiver and residential staff. How can we be inclusive? There are many ways we can be inclusive. I had already touched on all of this earlier, but if national fitness certifying agencies were able to provide training and special needs certifications, more people in the fitness industry would be comfortable because as a personal trainer, you know, there's risk management there, and you want to make sure that you're keeping populations that you serve safe. And, you know, this special training and such as, you know, frail populations and prenatal, postpartum, senior fitness. This is another level of fitness training that can prepare fitness professionals to serve the needs of individuals. Best practices in screenings and sensitivity training using successful service models from other public health and healthcare systems. There are some healthcare systems in other parts of the United States and in New Jersey that have sensitivity training for staff and have adaptive approaches to preventive screenings to help individuals with disabilities be more comfortable. And then becoming a DDD approved provider. That's another way that an individual who has a service in the community, whether it's nutrition education, health coaching, exercise program, can register with the Division of Developmental Disabilities to become a provider. So Lynn, this is how I got in touch with Lynn initially. I was just testing out the system because I was a provider once years ago when I was a personal trainer. And now there's a new way of doing it with fee for service. They ask everybody to apply for an NPI Medicaid ID number. And so I was just looking through this to see what the process was. So I said, okay, if I was looking for a fitness agency, how would I find them? And I put in fitness, and certified fitness for special needs came up, and I looked them up and I called them, and I got Lynn on the phone, and she's here today. So thank you, Lynn, for being here. But people can find her through this database. So I encourage anybody with a fitness or wellness or lifestyle service to become a registered provider so that you are yet another available resource in the community for an individual with disabilities. And this is the DDD website. Goods and services is a category under which you would register. And then lastly, well, it won't let me share my last slide, but I will tell you. How's that? Okay, it won't let me share my last slide. So I will tell you that the North Jersey Health Collaborative, through a generous grant from ScreenNJ, is doing a series of webinars on colorectal cancer screenings for individuals with developmental disabilities. If you're on our mailing list, you will be receiving invitations to these webinars. And again, that's another way that we feel that we could help through this public health collaborative. We are bringing this important information to the public and the community. So there's a lot always to talk about, but that's all I have for the moment, because I would really love to hear your comments and take any questions that anybody might have.
So just Laura, I want to say thank you for the great presentation.
Thank you.
Actually, it brings to part, and this is a disconnect, that I was doing a lot of this work as well. But I think in trying to get and help the health of our disabled community by working together in a health and wellness program, we also create that community of support for both those individuals and for their caregivers, and then make it a more positive connection to getting the necessary screenings done that are so necessary to be done, and have that connection to doing that. In my time, I worked with SONJ, and we brought SONJ in to do training with us in order to better to train staff in working with individuals with intellectual and developmental disabilities. And I can't say enough, I'm hearing it every This is our 5th ECHO session. That training is so important in delivering the best possible services to this community that we need to.
Absolutely, absolutely. So with that said, I think that's a wonderful segue without putting Amelia Hamilton on the spot. Amelia, would you talk briefly about how people could get connected with SONJ by referral or direct contact with you?
Yes, absolutely. And good morning, everyone. Thank you for having me on this call. This is my first time being on the ECHO series, and a lot of great information being shared on here. So thank you. Just to give a brief little overview, our state is pretty much split up by different areas. So we have 13 different areas throughout the state, and that includes the different counties throughout New Jersey. So I work at the state level here, and then we work with our local areas. So each local area is run by a volunteer area director. And then we're always looking for volunteers to get involved within those local areas or at the state level. So we have done a lot of health and fitness work, especially in the last year, just due to the pandemic. We do offer health screenings as well for our athletes. And unfortunately, during COVID, we were not able to do any in-person screening. So we were doing a lot of health and wellness work. We were able to expand those programs virtually on Zoom. So it was great because we were able to reach different athletes throughout the state, although we were not able to be in person. So if anyone is looking to get involved with any of those health, wellness, fitness, yoga, nutrition education, anything like that, we are always looking for volunteers to get involved with us and expand those programs. So I can put my email in the chat, and if anyone is interested, they can reach out to me directly. So thank you.
Thank you. And as I had said in our email, the North Jersey Health Collaborative, we are all about connection. So our conversation will be continued and we will find ways to partner with you. Thank you. Thank you. I would like to call out to Lynn. Lynn, forgive me if I'm mispronouncing your name, Alof?
That's correct.
Thank you. So Lynn, now I told you how I came to know Lynn. I found her in the provider directory. So Lynn, would you kindly share what the process is or how you became a provider? And I know you're a special education teacher. Can you talk to our participants here on the value in becoming a DDD provider?
It's really been a wonderful process for us. We started, the owner of our facility had a son who was autistic, and I was a special educator for 40 years, and we started talking. I used to work out. I worked for Easter Seals, and after I retired, I had a client that wanted to work out with me. She came to the gym. We started working out together. I approached the owner and asked her if this would be something she'd be interested in pursuing. And we got our, we went through DDD, we're approved provider, and we have about 50 clients. We've been doing this for 5 years. It's really been wonderful. What you were talking about is the health and well-being of clients, and that's something that we really focus on. I can tell you, though, some of the problems are the transportation for our clients and staffing for our clients. Often, if a client doesn't show up for an appointment, I'll call and the staff will say, oh, they didn't really feel like coming today, or we didn't have a car, or we didn't have a staff member to take them. So, and we get a lot of referrals from parents. The parents are very interested in having their son or daughter participate. And if they're living in a group home, then they're really dependent on the staff to provide the transportation and bring that client. And that has really been problematic over the years. We also try to run a lot of groups. In the summer, we met at a local park. We brought our clients there. We did something called All Sports, where they did basketball, baseball, bocce ball, which was really wonderful because I felt if they were home on a weekend, they would be able to participate in family events with everyone else. So it's been a great program.
Wow, that's amazing. So for anybody on here who is a wellness provider or anybody who has the opportunity to refer a client or a patient for wellness activities, do you have any advice on using the DDD directory or the registration process?
I would just go on the directory and see who's available. A lot of our clients participate in Special Olympics. I know now they're opening up the young athletes, the 2 to 7-year-olds, because we get a lot of young children that want to come to our program, and we're really like more 18 to 50-year-olds. So we refer them to Special Olympics. And as I said, a lot of our clients participate. Our local Y does a lot. They do a lot of swimming programs. So if another fitness facility is interested, they can go to the DDD website and start the process. It's not that difficult. The difficulty sometimes comes in getting a client approved, because I hate to say this, DDD often doesn't see the value in exercise. So we've gotten clients denied where we've had to go back. I shared with Laura why I went through Paul Aronson a few times for clients that didn't get approved over the years, and he was very helpful. So I would just, if a fitness facility is interested, they should start the process. They can reach out to me and I can help you in any way.
Thank you. And we will be doing a special obesity and fitness forum on the disabilities population to help anybody in that industry get started here. So in terms of screenings, that again is the other part of it. Personal trainers are not healthcare, fitness instructors are not healthcare providers. But when somebody's engaged in that kind of healthy lifestyle flow, I know when I was an exercise instructor, I would shout out to my class in the middle of, leg lifts, October's Breast Cancer Awareness Month, get a screening. There are so many ways to spread the word. And the more demand there is for services, the more demand there is for adaptive measures for screening, I think the supply side may begin to meet the demand. So I encourage everybody to please continue to advocate for the needs of individuals with disabilities. So the other thing I just want to underscore is that disability is not an illness, right? And some of our previous speakers have mentioned this, but we also need more of a whole person approach to the individual with a disability. Lots of times individuals with disabilities are seen by specialists, neurologists for certain medications that they need. And we, can, by encouraging wellness activity, can, increase this whole person outlook. So I'm going to hand it back to Sherry to see if you have any more questions.
So are there any more questions? I think probably the goal is to establish these community programs, and is just another outreach to service this community. Len, we thank you for your input on how it evolved. I think my experience is it does evolve because of a personal connection with somebody, and then those talents coming forth to help build a program. Does anybody have any further input on that?
Yeah, Sherry, I'd love to piggyback off that statement. So by trade, I'm actually a nutritionist, and I know in the traditional curriculum, especially when we're learning about nutrition education and planning programs, implementing programs, there's never really any talk about programs that are specific to individuals with disabilities. So I was really happy. Actually, Laura, I have to buy that book by Beth Marks.
Beth Marks,
on
Health
Amazon.
Matters.
I'm ordering a copy right now of this is really, really crucial. We don't have this integrated and embedded in any of the curriculum by the different colleges and universities. So I think
it's wonderful. And UIC, has a disabilities center, and they do great work. So.
And there's just a lot of standard nutrition curricula out there. but there's, no recommendations on different accommodations or really how to specialize a particular curriculum. For example, Cooking Matters is really, really popular. It's evidence-based. It's a great curriculum for youth, teens, tweens, and adults, but definitely there's no accommodations within that, suggestions for accommodations within that curricula. So yeah, I'm always love to learn more if there are any current programs throughout the state of New Jersey on a nutrition level. I love to learn a little bit more about that.
Actually, that would be a wonderful resource that we could put up on the collaborative, because as we do the community health improvement plan, we are going to be, integrating special needs inclusion in this. If nobody has any more questions, we are going to wrap up on time today. I would just like to announce that next week's topic is childhood healthcare trauma and transitioning to adult healthcare. So now we're going back into the healthcare topic area, and our speaker is Jocelyn Berrios, and she is a licensed social worker, and she has worked for several years with the Children's Specialized Hospital. So we are going to be moving into how past healthcare trauma informs current healthcare and attitudes toward receiving healthcare. It's going to be very, very serious and important topic. And we hope everybody can join us.
And we just put in our chat box just a really quick evaluation link. We promise this is really painless. It will just take about a moment of your time. We'd love to hear your feedback, as well as if you have any suggestions for future topics. And we would just like to thank everyone for your time today. We'll be uploading this recording onto Box, as well as all the resources that we shared today. And a really special thank you to Sherry and our guest presenter, Laura. This was a truly fabulous presentation. So thank you all.
Thank you. Thank you, Michelle, for hosting, and thank you all for being here today.
Thank
And
you.
we look forward to seeing everyone again, same time next week, Tuesday at 8:30 for that, dialogue on childhood trauma and its impacts. So
wonderful.
Have a great week, everyone.
Have a great day, everybody. Be well.
Thank you, everyone.
Thank you.
So much. Bye.
Bye-bye.
Bye.